if we are able to identify these patients, how do we intervene now? How do we intervene now? Again, until we have clinical trials to tell us or guide us how to treat these folks with the current agents, is there something we should be doing differently? So I talked about a couple studies that, although they didn't look specifically at these patients, have subsets of patients that were treated with any given therapy who fell into this high-risk category. And we know with drugs like bendamustine, patients that are double refractory or alkylator resistant and rituximab resistant have about a 60% response rate. Idelalisib, which is approved for relapsed follicular lymphoma, also has response rates around 60+% in patients who are failing chemo and rituximab. Lenalidomide and other combination therapies also have response rates upwards of 50 to 60% in this double refractory population. And finally, I think we shouldn't ignore methods like autologous stem cell transplant. In transplant, it's been pretty clear that if you take a patient who has a early relapse, or I should say is refractory to one line of chemotherapy, this does not necessarily predict long-term poor outcomes in these patients. In fact, some retrospective looks at patients who went through transplant suggested that even in patients who had short remissions, you could get prolonged survival. In fact, some patients, around 60% of patients following auto transplant, will have a long-term remission.